and thus the urinary osmolality is high. We talked before about treatment of hyponatremia from SIADH, but now I'll mention treatments for other causes of hyponatremia. Just like in SIADH, fluid restriction alone can often be helpful to raise the serum sodium. Sometimes concentrated saline, 3% saline, can be used. And then finally, there are drugs called Vaptan drugs like Tolvaptan and Conivaptan. These block ADH, and they've been shown to be effective in treating hyponatremia associated with heart failure only. When you are treating a patient with hyponatremia, you have to be very cautious in raising the serum sodium level because you can cause permanent brain damage and even death. Raising the serum sodium level too quickly can lead to central pontine myelinolysis, which is also called the osmotic demyelination syndrome. This is associated with overly rapid correction of hyponatremia, usually raising the serum sodium more than 10 milliequivalents per 24 hours. Through a poorly understood mechanism, if you raise the sodium too quickly, it leads to demyelination of central pontine axons. This causes a lesion at the base of the pons, and patients lose their corticospinal and corticobulbar tracts, which are the major motor tracts in the pons. This leads to a quadriplegia that can be similar to the locked-in syndrome, and it can lead to death. And for this reason, in clinical practice, when you are treating a patient with marked hyponatremia, you carefully monitor the serum sodium level and don't let it go up more than 10 milliequivalents per 24 hours. So now we'll switch gears and talk about the opposite problem, which is hypernatremia. This is where the serum sodium level is too high. Just like hyponatremia, many of the symptoms relate to central nervous system dysfunction. The symptoms of severe hypernatremia include irritability, stupor, and coma. You can basically divide the causes of hypernatremia into two major groups. The first group are those causes related to water loss. When you lose fluid, especially from the skin in sweat and the lungs in water vapor, you lose much more water than sodium. If you aren't drinking free water, this can lead to hypernatremia. In this setting, the ADH level will be high and the urinary osmolality will be high. The body is responding by concentrating the urine and retaining free water. It's just not able to retain enough water to replace that which has been lost in the skin and in the lungs. The second group of causes fall under the heading of diabetes insipidus. Diabetes insipidus occurs when there is loss of ADH activity, and it can be either central or nephrogenic. A central cause means there's loss of ADH release from the pituitary, and this can occur when there's central nervous system damage, such as in trauma or in tumors of the central nervous system. There's a rare nephrogenic form of diabetes insipidus that is congenital, where babies are born unable to respond to ADH. And then finally, there are a number of so-called acquired nephrogenic causes of diabetes insipidus, where for one reason or another the kidneys become unable to respond to ADH, and this leads to hypernatremia. In certain electrolyte disorders, nephrogenic diabetes can occur. When patients have hypercalcemia or hypokalemia, the kidneys can become poorly responsive to ADH, and that can lead to diabetes insipidus. In addition, there are a number of drugs that are associated with nephrogenic diabetes insipidus. I've listed two of the classic ones on the screen. Lithium, which is a psychiatric drug, and amphotericin B, which is an antifungal drug, are both classically associated with development of diabetes insipidus. The symptoms of diabetes insipidus are polyuria and polydipsia. When there is a lack of response to ADH or a lack of ADH, the kidneys excrete excessive free water. This leads to polyuria. The patient then gets dehydrated and therefore they are thirsty all the time, and that's polydipsia. And these are the same symptoms as diabetes mellitus. That's why it's called diabetes. Diabetes mellitus, as you may know, is caused by glucose in the urine. And years ago, when people tasted the urine of patients with diabetes mellitus, it was sweet. Therefore, they named it diabetes mellitus. The word mellitus means sweet. Diabetes insipidus, which has similar symptoms, although a completely different mechanism, had tasteless urine, and therefore it was called diabetes insipidus. The word insipid means lacking taste. Let's talk about how you diagnose diabetes insipidus. You suspect the condition when a patient has polyuria and polydipsia. Now, I've listed diabetes insipidus among the causes of hypernatremia, but in many cases the plasma sodium level is actually normal. That's because water loss stimulates thirst and patients replace the water that they are losing. Hypernatremia only occurs if they don't drink enough water, and this is more common in patients who have a central cause of diabetes insipidus. The central lesion can affect the central nervous system and impair the thirst mechanism. And then finally, when you check the urine osmolality in patients with diabetes insipidus, it will be low, usually in the range of 50 to 200 milliosms per kilogram. This indicates that the kidneys are dumping free water and therefore the urine is very dilute. Once you suspect the disorder based on polyuria and polydipsia in a dilute urine, you then ask the patient to restrict fluid. After 8 hours of no free water intake, the urine should become concentrated. If it remains dilute, this means there is absent or ineffective antidiuretic hormone. You can then administer an analog of ADH, either vasopressin, which is ADH itself, or desmopressin, which works like ADH, and this should concentrate the urine if the kidneys are able to respond. If the kidneys do not respond, it means the patient has nephrogenic DI, and the problem is that the kidneys are unable to react to ADH. If there is concentration of the urine, it means the patient has central DI and there's a loss of ADH release from the pituitary for some reason. The treatment of hypernatremia is usually water, ideally PO. In patients who are able to drink, you simply encourage them to consume free water. You also can administer intravenous fluids that lack sodium. There are fluids called D5W which contain dextrose so that they are isotonic with plasma but do not contain sodium. Patients with central DI can be treated with desmopressin. I mentioned this earlier. It's an ADH analog. It has no vasopressor effect like vasopressin, so it won't raise the blood pressure. The problem with vasopressin is although it replaces the lost ADH in diabetes insipidus, it's also a vasopressor. That's how it gets its name. So it will constrict the blood vessels and raise the blood pressure. That won't occur with desmopressin, and that's why it's a nice treatment for diabetes insipidus. There are two special therapies that can be used in nephrogenic diabetes insipidus when the kidneys are unable to respond to ADH, and those are thiazide diuretics and nonsteroidal anti-inflammatory drugs. The mechanism of thiazide diuretics is counterintuitive. You might think, why give a diuretic to a patient who has polyuria? But it turns out that thiazide diuretics can be helpful. This is because they cause a mild state of volume depletion, and this leads to an increase in proximal tubule resorption of sodium and water. In other words, more water is pulled out of the nephron in the proximal tubules in patients taking thiazide diuretics. This means less water is delivered to the collecting tubules, and as a result, there is a paradoxical antidiuretic effect in the setting of nephrogenic diabetes insipidus. NSAIDs work, as you may know, by inhibiting the synthesis of prostaglandins. This is helpful in the kidneys because prostaglandins are ADH antagonists, and thus when you administer an NSAID, you can see an improvement in the symptoms of polyuria and polydipsia. And that concludes our module on sodium disorders.